everybody. Welcome to, amazingly, our second to last Breakfast with the Expert for the entire, for this academic year. I can't believe that we're already here. We only have one left that will be at the end of April. So thank you for being here this morning. Thank you for supporting the program. It's my pleasure this morning to introduce Mr. Ryan Youngblood. Mr. Youngblood is the administrator at Princeton Transitional Care, which is part of Quillen Rehab, and that's a Mountain States Health Alliance facility. And he'll talk more about what Princeton is and what they do there, but it is a TCU, it's a Transitional Care Unit. Prior to that, Mr. Youngblood was administrator in Arkansas and took over a facility that was that had some challenges clinically and regulatory, with some regulatory issues. Went in there, committed himself to that, made a huge difference. So Mr. Youngblood has a lot of experience in quality improvement and knows the regs that surround long-term care. Now, prior to that, he was a marketing coordinator for, it was Liberty Hardware, right? Yep. Yeah, and Liberty Hardware, he worked in sales, so the guy's a salesman on top of what he does. And I think something we've talked about before is in leadership, really how you sell things is what predicates whether or not you're successful. So that was a good background for him. In his time there, went from an annual revenue, am I saying this right, about $16 million to $250 million over a 7-year period. So he's had a lot of success there as well. All of that's wonderful, but I think the thing that he would say is most important is he's very happily married. He has 4 children. They live in Bloodbowl. He's a member of the Church of Jesus Christ of Latter-day Saints. He serves in various leadership capacities there in the church. And well, let me say this. Apart from being a personal friend to me, he's also he's been a good friend of the college and the department. He's done some things for me without much notice, and he's got 2 of our field placement students. He's got Ali and Morgan, and hopefully we'll have some more in the future. So he's been a good friend of the college.
Thank you, Mr. Chesley. As I thought about, first of all, who just came here for the free breakfast? Okay. All right. Me too. So one of the things that's really interesting about being in administration is that if you're aware of anything about healthcare, you realize that healthcare is changing constantly. There's nothing that stays the same. It's probably one of the most fluid industries that's out there. If you're getting into healthcare because you want to make millions of dollars, you're in the wrong field, especially with the way things are changing. I tell my boys, I have 3 sons and a little girl, and I tell my boys, I have a master's degree in healthcare administration, and I tell them you need to go to trade school. That's because you'll make more money, better bang for your buck. But my boys don't want to be welders, so I think they're going to pursue other venues. Now, one of the things that, if you look at healthcare right now, how many of you have seen that video? It was a commercial, came out about 3 years ago for some health fitness center. It shows 2 people going up on an escalator. Everybody ever seen that? They go. Guys holding the donut. Both the man and woman, they go up on the escalator, and I tried to find the video last night. They were going up on the escalator, and as they get about halfway up, the escalator stops, and they're stuck, and they're screaming, help, we're stuck on an escalator, can anyone hear us? Haven't seen that video, look it up. A lot of times in healthcare, people will consider themselves, with the changes, stuck on an escalator. They think, gosh, I just can't change, I can't move on. Somebody's going to have to step in and help me. Unfortunately, the way things are, if you're not thinking about things to develop your system, to develop your facility, as an individual facility, then you're going to get left behind. You're going to get stuck on the escalator and have to worry about someone else coming in to help you out. Okay, I know that's a really odd analogy, but so what I'm going to talk to you about is one of the things that Mountain States has done to help develop their system, help offset some costs, increase some revenue, also to help with the whole continuum of care, basically, helping people get home faster, reduce the length of stay in the facility. Everyone here familiar with bundled payments? That was a question you guys can answer. So, raise your...
You can remind us.
Okay, so bundled payments. In the hospital, you're going to have, they've gone to a almost complete bundled payment system. Basically what it is in an effort to take a person's care from beginning to end to ensure that they're getting the correct care, they're no longer allowing facilities to bill just by procedure, okay? They're looking at the whole system of care. So that being said, not just the hospital and the physicians involved getting separate payments, they're giving one lump sum, awarding that out, and making it so that each of them have to communicate. Well, in the process, for example, how many of you are familiar with the 30-day readmission issues? That's a big problem, right? So you have 30 days. During that 30-day time, if someone's discharged from that hospital, they come back under the same diagnosis, the hospital's not going to receive any additional payment. Those physicians are not going to receive any additional payment. So that is a big concern for a health system, because all of a sudden you've discharged somebody, they relapse because you felt that they were ready to go home, and you're not going to get paid any extra money when they come back, and they may stay twice as long on their second visit. So it gets kind of expensive. It's hard to keep your doors open, and even though you say you're a nonprofit organization, you still have to pay your salaries. You still have to pay the bills. So what I'm going to talk about is one of the things they came up with is something that's known throughout the nation as a Transitional Care Unit. It's a short stay facility, and what it does is, for example, Princeton Transitional Care here in town, our average length of stay last month was about 10 days. Okay, so we get people in and we continue their care of these highly acute patients, and then we find out where they need to go home, whether they need to go home, whether they need to go to home health, or whether they need to go back to the hospital. And we look at it as a big picture item. One of the things, and let's see if I can get this to work here. One of the areas that we like to look at is through our communication tools. And I can kind of pick on my two interns a little bit. The communication is probably the most important thing that happens in a facility. From the start of a person's stay to when they're discharged to home health, determining on a daily basis what is necessary for that person's care in order to get them to that point, it has to be known by everyone. Now, let me give you a brief overview before I dig into some of these slides. Princeton Transitional Care has a 34-bed unit. We have everything from social workers to, I have the director of nursing that answers to me. We have physical therapy, speech therapy, occupational therapy. On site, we also have respiratory therapists that come in for those people that have respiratory issues, tracheostomies, anything that we would need to take care of, we have on site or we have a contract with. We also have on-site pharmacy. That's a huge thing. So these tools of these communication tools are all so important in that we communicate all that to all those people that are involved. And one of those tools is the huddles. Anybody here heard of a huddle besides college football? We got huddles. We do daily improvement boards, which we call DIBS boards, and we have care plan meetings. And let's look at our huddles. So these huddles are discussions that occur at each shift change, okay? What this involves is all of my nurses at each shift change, they will meet together, discuss what patients they've taken care of, find out what their immediate needs are, and then if they have any other needs, for example, if someone all of a sudden had a change in skin integrity and they need to be turned every 2 hours or every hour, then that is passed along. No longer can it just be the charge nurse that knows all the information on these individual patients. It has to be the charge nurse disseminating this information to the other shifts, to the CNAs, to the back out to the social workers who are responsible for working with the person's individual psychosocial needs, and for the therapist to understand what changes have occurred, if any changes or if any advances. So that's one of our main things that we have. Those huddles occur at each shift, and some of them are more productive than others. In addition to huddles, we have what we call our daily improvement boards. These boards are, ours right now is a portable board, and I think Morgan's had plenty of experience in updating this. Ours is just made out of, you know, like your science project board, you know, when you're in middle school. It never goes away, by the way, all those things, so keep those skills finely tuned. You'll never know when you're going to need to do a 5th grade science report again. You're going to need to do it in your college classes. You'll need to do it here in your workplace. So what the importance of this is, anything that we have that we feel like is absolutely a visible priority for our unit, it goes on this board. And usually what we'll do is we'll find 3 or 4 items, and we will track those 3 or 4 items over until they're no longer an issue. I think we've had on there things such as productivity. We've monitored falls this way. And what these do is this board will come out every day, and a lot of times my shift nurse or my director of nursing will bring the board out, and they'll just take it over to a few of the people there, discuss it with the issues that have come up for that particular issue on the previous shift, to let them know, hey, here's where we've fallen in. We had, you know, Miss Smith fell last night. Our overall falls for the month, we've had 7. She fell, but she didn't have an injury, and kind of detail out what some of the precautions that they've put in place, whether they've decided they want to put a bedside mat, or they're going to put the bed in a lower position, or if she needs to have 2 people to assist her in moving from the bed to the wheelchair, or if she's just getting up because she's feeling like she's going to be incontinent. So maybe we need to round a little more often with her so that she can get to the restroom quicker. Okay, so this is one of those things that anything can go on this board. That's the great thing about it, anything. And it's determined by the unit as to what they want to do. And it should be a perfect system, but it's not always a perfect system. In fact, we're still working some of the bugs out on ours. We also have care plan meetings. Now, we do our care plan meetings a little differently because we are a short-term facility. We meet every week, and we discuss the new patients in the facility. You know, under normal circumstances, you'd be reviewing these people every 30 days or 90 days, depending on the circumstance. And you would have them, have the family members come in and discuss what their expectations are, any issues they have. But we also, with them having a turnover rate of about every 10 days, we have the families come in if they want to. We discuss their goals, their needs, any individual issues that we're seeing come up, anything that might be impeding them from having any therapy, things that would hinder their overall ability to give care, okay, or receive care. This meeting, and I want to emphasize this meeting is probably the most important meeting that you're going to have. Especially on a skilled nursing unit. And the reason is because you get true feedback here. Your daily huddles are a little rushed because you're trying to hurry and get people out to take care of the care. And your daily improvement boards are just a monitoring system. This truly is exactly what it says. It's a care plan meeting. You are developing the care for an individual patient. Now, there are lots of things that can go wrong in someone's care. Now, you think of all the different anomalies that there are. Consider your drive to school this morning, okay? Think of how many different variables you encountered on your drive to school this morning. You have other drivers. You may have had a little bit of rain. You may have someone's headlights in your eyes. These are just a few of those variables. Now, you change these variables into a healthcare setting, and you look at the timing of your nurses, the timing of your medications, the different ability for a person to react to the medications, their mental state, whether or not they want to get up and go to therapy or receive a treatment. All these things come into play. So when you have one of these care plan meetings, and you're meeting with the director of nursing, you're meeting with the social workers, you're meeting with your pharmacist, you're meeting with your dietitian. all of these different people come into play, and they discuss these things that they're seeing as barriers or that they're seeing as successes with the family members to either give a motivation of one sort or another, or to get a better understanding of where we can make a change in our ability to care for this patient so that that person can get individualized care. Yes, yeah, sure.
So when the patient and or the family is at this meeting, is the meeting with the team of providers?
It is.
Or with individual members of the team?
It's with the entire team. We try to have our entire team there, and you don't always get everyone there, but you have, we'll have, for example, our meeting is today at 1 o'clock. And we will have, I think we'll discuss 20, I think there's 21 patients on the list for today's meeting. Now the meeting usually lasts an hour, so you can imagine that not everybody shows up. And then sometimes it's as quick as taking a look at their chart and determining, okay, this is where they are, what are you seeing as a barrier, are you seeing anything, and then you're done. But when the families come in or the patient comes in and they say, here's a problem that I'm having, we spend more time in trying to determine, hey, yeah, this is what I'm seeing. What are you seeing there, John? And he'll speak up and say, well, here's the problem that I'm seeing right now, and what can we do to help you to get past this, so that we can get you home or get you to a long-term care facility, whatever the need may be. So.
How often do you get your CNAs there? Are they able to make it to this?
Right. I'll be honest. They don't make it to this as much as I'd like to have them there. One of the issues that we're having right now is, as a system, we're having trouble finding CNAs. Right now, I'm only running maybe 2 per shift. So our nurses are having to do a lot of primary care.
Wow.
So. But,
pay nurses to do primary care.
Yeah, but it's kind of an expected thing at our facility. We spread the wealth, so to speak. They know that they're having to do primary care, but our nurse to patient ratio is very good. So it's, with 34 beds, with all these sick patients, it's it's really better to have a nurse that's willing to be in there hands-on and be able to see every little detail and not have to worry about that. But the other side of that is, when you're having to deal with showers, things like that, it is better to have some CNAs. We have a program at Mountain States they call a PCP program, where they train their CNAs to do, they can draw blood, things like that. So there's a lot more ability for them to really give better care than just be someone who's there to change someone's brief or to take somebody to the shower or to the bathroom. So. Anybody else got any questions? I'm kind of blitzing through this, so.
Are you currently looking at hiring any new CNAs?
Yes, we are. You looking? No.
Michaela's a CNA.
Are you?
Yeah, that's what I was asking.
Yeah, we are looking. So I know this wasn't intended to be a recruitment session, but yeah, we're looking. Anybody wants to come work as a CNA? It's interesting. And I'm going to digress a little bit. One of the cool things about, and Colin can kind of attest to this, about being an administrator is, when you go into long-term care and you go work in a skilled nursing unit, and I don't know how NHC did any of theirs, but the expectation on me was that I was going to rotate through, in my AIT program, is that I rotated through each position in the facility. And to put a little plug, if you have the opportunity to do an AIT program, it's probably the most valuable thing that you will do. And the reason is because you do see every position. You go through CNA training, you go through training, you sit and spend a lot of time with nurses. You spend a lot of time with your social workers. You spend a lot of time in dietary to really understand what it is that they do on a hands-on basis. That was probably the most eye-opening thing for a lot of reasons when I went through my CNA training. It is a hard job, very hard job. Probably the most difficult job in the building, in my opinion. Yeah.
What is an AIT program?
It's an administrator and training program. What it does is, in order to, and I believe if you have, and I have to look at how Tennessee is set up. I'm not real familiar with it, but, and you can probably speak a lot better to that.
We actually got a meeting this Friday, guys. It's for the field experience students, but I mean, we can open that up to anybody. We're going to discuss how you gain licensure as an administrator. That's something you guys can do with your bachelor's degree. I don't know, we don't talk about that a whole lot, but that's with your bachelor's degree, you can be in an executive position, and it's fun, it's thrilling, and it's lucrative, and there's a lot of opportunity. So the plan is to have the meeting Friday at 12 o'clock, but it's downstairs in the conference room. If you're interested, please email me. If I need to change the venue to a bigger spot, just let me know if you guys are interested.
Just to add to that, I mean, the field experience hours that you're required to do can count towards the hour requirement for the administrator in training program.
I think it's 400 hours, right? Something like that.
Our field experience, yeah, the minimum required is 400 hours. So you're already a step ahead. You know, those hours can count towards the AIT requirements.
Yeah, it's the field experience. You know, I'm not going to speak for Ali or Morgan, but I think that it gives you a good idea how to put all the things that you're learning in this program into practice. I remember in my AIT program lasted a year, okay, with us, and so during that year you rotate through and figure out, you know, where your strong points, where your weak points are, and where you really need to study and understand things better. You know, with my background, I had a lot of varied background. You know, I went from sales and marketing for a total of 9 years, and then shifted into a financial analyst position for about 2.5 years, and then I ran the company that I was with asked me to take over and develop a logistics department and continue with accounts receivable department. And then I got the brainy idea to go into healthcare. So my poor wife, she's seen me go through basically 3 careers in our marriage. So it's just one of those things, though, that has helped me understand, like when I got to the AIT program and I started working in the business office, it wasn't as much of a stretch for me as it was for a lot of other people. The real stretch for me was dealing with, you know, social services, things like that, where you were really trying to understand what it is that the patient needs. You know, I'm good on the surface, but once I have to dig in, it's a little sketchy. You know, so. One of the things about this meeting, though, is that if you'll take the information from a care plan meeting, from that meeting, and really digest the information you receive, that information can fix a whole slew of problems, not just with issues regarding the patient, but it helps you understand your regulatory issues in the facility as well. Now, as a skilled nursing facility, we're governed by the state. That's our main, just like a long-term care facility, we are governed by the state. In fact, I was kind of joking this morning, one of our other facilities, we're usually within 24-hour window, the state comes in for our annual, and they came into that facility last night, so they could pop in any minute. I may get a phone call, I got to run out. But those surveys that they do, they go through all the regulations, they look at your facility and find out where your deficiencies are. And it's not a fun process, but it's a good learning process. And especially as an administrator, your first one in that facility, you may think you have your hands around it, but as soon as you think you have your hands around it, the state comes in and they say, no, here's really where your focus should have been all along. So this will be an interesting thing for me. Moving on, another area that we do is our job is to reduce the length of stay in those acute care settings, okay, and to limit the readmissions. Now, one thing that we do, and we do well, is that we admit very highly acute patients. And by that I mean we admit people that have a multitude of problems that normally you would not send out to a community nursing home. We are very well equipped to handle a lot of sick people, and that's kind of the way that healthcare is going. Okay, this is kind of the model of where healthcare is going because of this. You know, that whole continuum of care, starting at the acute setting, moving on down, even down to home health. These things, everybody has to be on board and understand, what can I do to take the pressure off of a system or a community. You may not be related, but and to speak bluntly, if you're not with an organization such as Mountain States or a Wellmont, if you are not directly affiliated with them, the ability for you to receive admissions, which is the lifeblood of your organization, if you're not able to receive admissions, then you're going to go out of business. So you need to develop your facility in order to be able to take these higher acuity patients. So that basically it comes down to a trust level. The hospitals have to trust you and understand that you can handle a certain patient load. Okay, that's kind of hard, especially when you're going from, you know, if you're looking at a long-term care facility that's been around for 20, 30 years, they've seen lots of changes, but a lot of times they don't want to change, okay? They're stuck on that escalator, right? They don't know how to get out of there. And it takes pretty heavy regulatory changes for them to either adapt or really go out of business. You know, in all honesty, competition is alive and well in the healthcare industry. We also have high staffing ratios. We deal a lot with our staff training and our equipment needs. We monitor our equipment needs very, very closely. As far as admission of highly acute patients, we admit people that we have lots of central lines in our facility. Lots of people that are IV on IV antibiotics. We get people in constantly that need trach care. Lots of tube feedings, and we get a lot of chronic drug abusers. And as you can see, if you're looking at central lines and chronic drug abusers, that's a volatile combination, because that person all of a sudden has direct access to do whatever they want to do to themselves. Okay.
I've got two quick questions.
Sure.
Are those central lines, are they peripheral or are they central?
We do both. Yeah.
You care for both those. Do you guys have to monitor? I'm forgetting the acronym already for some reason. The cloud seed. You have to monitor.
We do. We monitor that very closely. And one of the great things that we've seen over the last year is a huge reduction in those device-acquired infections. When I got there, I believe we were in the 40s, and since last June when I got there, this year to date, and our fiscal year ends in 2 months, we're down to 17. So we've reduced that dramatically.
That's a percent or a...
No, that's total number.
Total number.
Yeah. So.
And my second question: do you all service only Mountain States? Or do you receive admissions from other acute care? You know,
that's a good question. Mountain States keeps us so busy. We can. For example, I had one come in from Wellmont 2 weeks ago. So they came in from Bristol, and they had a lot of needs. So we ended up with them. We do take them, but we stay really busy with Mountain States. Our facility is directly affiliated with Franklin Woods. That's our books run right up under Franklin Woods. We just went through a crazy change in provider number to make that happen. And but most of our admissions come from the Med Center, as you can probably see why. I mean, the total number of admissions over there are dramatic. In fact, I have 3 liaisons that are on site. They actually have an office at the Med Center. So most of those referrals come from there. So
the Med Center patients tend to be very complex.
They are
medically needy patients, which makes them good candidates.
They are, and we get. With those complexities, you get more complexities. It's really an interesting dynamic. It's been a huge learning curve for me, going from a long-term care facility of 120 beds that had we probably averaged 30, 35 Medicare, HMO, skilled nursing in the facility, to strictly skilled nursing. Where, in my long-term care facility, we probably only saw, 35, 40 admissions a month on a good month. And then with this, we've had months where we've had admissions as high as 90. So when you have 34 beds, you're turning those beds over. So you really don't, the days of me going out and seeing Miss Jones in her room and having a long conversation with her and building those relationships are very minimized, because you really can't get to know someone very well in 10 days, so kind of takes that part out of it, which is really the part that I miss most of long-term care. But be honest, this is really my forte. This is a lot more, seat of your pants type of medicine here. It's constantly changing, so I enjoy that a lot more. So We also, this is Princeton's stats. You know, we average about 6 central lines a month. That's an average because some months we may not, like right now I think we only have 2, so that's great. All of our nurses are trained to handle trachs. We average about 23 IV antibiotics a month, and we have a continuous flow of these chronic drug abusers. Why do you think that we would have that constant flow of drug abusers?
I guess in part because I think we used to have a rehab facility, but either it no longer exists, or I mean, we really don't have many options for them to go.
There's very few options, and one of the issues that you run into is that your physicians are kind of caught in a bind. You know, we're really the only country in the world that requires our physicians to be responsible, you know, from beginning to end for someone's care. And someone that has no care for their own life shows up at the medical center in the ER, they're required to give care to that person. And then if they discharge that person out of the system, a lot of times that person, they discharge and it could end up, you know, basically coming to their demise. So as a physician, you really don't want to discharge this person out in the community until you know that they're done with their IV antibiotics.
Is it the lack of a payer source? Is that why
There's a lot of lack of payer sources that we get. We get a lot of charity, but you know, that's what our role is. That's the thing. That's what our role is. And because of that, we have to do things like this. We run higher RN ratios. You know, we do that. We have, you know, one of the things that I think I don't want to give credit to the wrong person, but one of my interns said that one of the things that stood out to them most was that we have fewer beds. So that's an advantage, and it really is a huge advantage for us. I hadn't really thought about it until they brought that up, because with fewer beds, you can really give a lot of focus. If you have 120, 150 beds, your nurses are spread thin, super thin.
Again, I had a question.
Oh yeah, sorry.
Does that 30-day readmittance apply to the drug users? Because, you know, they relapse.
Every human being, it does. But you know, if you also look at now, and it's interesting. You can't take away someone's free will. You know, you can tell them all day long this is bad for you, but you can't take away their free will. So, you know, you have to kind of, there's a funny balance. They can say, well, I don't want to receive any more care. They sign out against medical advice and they go, and then, but you know, at that point, you're talking about looking at all the legal ramifications of, and unfortunately, as healthcare providers, you will come to understand the legal ramifications of a lot of different things. You know, society as a whole wants to pin the blame on anywhere they can, and they look at healthcare systems as having deep pockets. So you're going to have, that's going to come up more than once in your careers. So, yeah. So you just have to, you know, you really have, that's why documentation is so important. And I can't, I'll preach that from the highest mountain. Documentation is really, really important. Keep careful notes as an administrator, you keep careful notes as nurses, because when you pass that patient off to someone else, they need to understand what the big picture is. Going back to that communications issue, they have to understand what's going on with that patient. If they don't, who's liable? Okay, the one that accepted the care without understanding the big picture, or the one who didn't pass off pass the person off with enough information. There's a lot of gray area, okay? And be honest, attorneys will have a full day with that, okay? Other things we do is we have on-site nurse, and you should have on-site nurse practitioners or physicians, and we have physician on call 24/7. And just to give you jump right into what Princeton has. So we have basically a 7-to-1 patient to nurse ratio, which is phenomenal when you consider that most of those nurses are RNs. We average 4 hours and 3 minutes of nursing care per patient day. which is fantastic. The Tennessee average is only 1 hour and 41 minutes. So we are way up above and beyond the average of the state and the federal, which is 1 hour and 38 minutes. Physical therapy, we're averaging 34 minutes per patient day, and the average, national average and the state average are the same of 6 minutes. So these people are getting a lot of really good, solid care when they come into a TCU, which is probably one of the reasons that we're able to discharge fairly quickly. You know, like I said, we have 34 beds. We have a nurse practitioner on site 8 hours a day. Now that's great because some days, for example, today we'll probably have 3 nurse practitioners on site for those 8 hours. And tomorrow we'll have the same because we do have contracts with different groups. And then we do have our MD on call 24/7. Staff training, huge. This is not just one of those things that you just like, okay, well, so-and-so's got to get trained on how to handle a PICC line. These are actual evaluations that my director of nursing will look at our staff and say, okay, you know, Mary has a problem with this. She's just not comfortable with this situation. So we will look at her individually, even though she's been checked off and for her annual competencies, she's just not comfortable. So let's get her as comfortable as we can. Let's send her some additional training. And what we do is we will go and we will discuss this with the medical center. What we'll do is we'll coordinate all of our training through the medical center to find out what it is that they're doing, what their latest best practice is, to find out where we need to make changes in our own staff. And that's really how you stay ahead of the curve. You know, if you're finding out that, you know, for example, when I was in Arkansas, we found out that there was a huge need, and I cannot remember, save my life.